Simo, and I am doing a presentation on Chapter 14, Psychological Disorders. This is the introduction to my video, and stay tuned so you can see the rest of it, and hopefully you can learn something about our Psychological Disorders chapter. Okay, with us today we have a special guest. I guess I could call her. She's one of our clinicians here where I work, and she was kind enough to assist me with my project. I'll let her introduce herself.
Hi guys, my name is Erica Nunez. I am a licensed marriage and family therapist. I've been working with the county for over 6 years. I started out in the outpatient clinic, so serving our population and our clients, and currently I am still doing that, and I'm also helping with the internship program. So part of that includes teaching our resident doctors about different theories in psychotherapy overall.
Wow, that's amazing. I'm so glad that you were able to help me with this, because this is right up your alley, and obviously right up what we do with behavioral health, right?
Mm-hmm. Yeah.
So I have to do chapter 14, which was psychological disorders.
Okay.
And I was really excited about this because I think it's a very important topic, and I feel that there's so much that we can learn about psychological disorders. It's an iceberg, really. There's so much information, so I'm thankful that I was able to get you to talk to me about that. But one of the things that I found very interesting about the chapter is how it was talking about the different models that are used to explain psychological disorders. So how exactly do you, as a clinician, utilize those models in your work?
Yeah, so that's definitely an interesting topic, and depending on who you ask, there are so many different answers that you can get. So different models, they're linked directly to different theories that are used when treating clients. So we have, for example, from the very beginning with Freud, psychoanalytic or psychodynamic. So that kind of looks at the origin of symptomology linked to maybe repressed feelings or repressed traumas that occurred when someone was younger, and how it leads to later symptoms in psychological disorders. And then if you kind of progress, then you go into behavioral models and theories, and that talks about how our behavior and what we do and what we see and what we learn, that can then lead to psychological distress. I personally like the cognitive theory model, and that talks about how our thoughts may influence our behaviors and our symptomology. So irrational thinking patterns or thought practices that need to be maybe challenged a little bit throughout the therapy process. So depending on what way you look at it, that can change how you approach a client in therapy and what interventions you might use. I don't know that there is one that really stands out as the main model that is used nowadays. I think a lot of people maybe take what they like from all different models. Another thing to consider is time in society. So depending on what was going on in the world, a different model may have spurred from that. So right now, a big thing is looking at culture too. So we're not just looking at a specific model, but you have to take into consideration everything that the client is experiencing culturally, socially, financially even. So models, there are so many different ones. Those are just some of the main ones, but it definitely does help in kind of getting a framework of where to maybe begin with the client and what they're coming in for, or their concerns.
Absolutely. I mean, think about it, how we began with drilling holes in people's heads and having exorcisms because people were having behavioral issues to, having now a book, the DSM-5, that actually helps us provide, diagnoses and symptoms and things and all of that. So that's fantastic. So just mentioned the DSM-5. So as a clinician, how often are you using that book?
Very often. So I don't have to take it out every day now, because over the years I've kind of been able to develop my own like mental category system of the main ones that are most often used in our outpatient clinics. However, in the very beginning, you're using it constantly because it's so specific on what a client needs to present or what symptoms they need to have in order to specify what diagnosis they meet criteria for. And that's really helpful to see, okay, what's going on in their life and how can we assist them with management and stabilization of these symptoms. So I personally love the DSM. At the same time, I do take into consideration what that information may do moving forward. If I put it at the top of the list of importance, I may be missing something else that might not be in the DSM, because the origins of it were medically based. So throughout the revisions of the DSM, they have taken into consideration things like I mentioned before, like culture or different classifications and wording of things and how that could be perceived. So
right.
Yeah.
I can see that. Just as the times change too.
Yeah.
There are things that, especially children, are more exposed to. So it changes, I think, the dynamic of how you have to approach the therapeutic part of it. So I'm really glad that the DSM is now taking other factors into consideration.
Yeah.
Instead of just it being medical.
I agree. I like at the end of it too, they have the cultural formulation interview. So it's something where you can ask questions to see, is this really a symptom that could be linked to a diagnostic disorder, or is it cultural related? And they have specific terms in there that I didn't know about before. And so having that, it's a good snapshot if a client mentions something to kind of just check yourself before you're just assigning a diagnosis.
Absolutely.
So I really like that.
No, that's great.
Yeah.
That's great. And, it's such a great, and broad, really, topic that you can kind of keep going on and on about it. But I really do appreciate your time. Thank you so much for talking to me and giving me that clinical perspective, because I'm not a clinician, but working in behavioral health and taking training and seeing what you guys do, it kind of opens you up a little bit more and gives you that insight of what to look for, not just in our community, but also in your own family. So I'm very thankful that we have these great resources available.
Yeah, of course.
So thank you so much.
You're welcome.
I wanted to take a moment to talk to you guys about the disorders themselves. There are quite a few that are discussed in the chapter, but I am going to concentrate on one specific one, which is schizophrenia. Now, schizophrenia is a severe disorder in which a person can suffer from behavior that is bizarre. They could have hallucinations. They could have distorted thinking. They can't distinguish the difference between fantasy and reality, right? So it is a long-term psychotic situation. It's basically something that they are going to have long-term. Okay, it can go from being very, very mild to very severe, and usually they're able to, with diagnosis, you're able to diagnose this late teens to early 20s. It affects both men and women, so it does not discriminate as to who is going to be triggered by this or actually experience this this psychotic disorder. So it's very problematic, especially in society, because when we see someone that might be someone that might be schizophrenic, you kind of see them talking to themselves, or they're pointing at things, and they are looking at something that is not there because they're in their delusion.
So I wanted to bring something up because in behavioral health we do this exercise called hearing voices, and what you're hearing right now is part of that exercise. So it's the concentration of a person that's having to hear this and having to keep a conversation like I'm trying to with you. It's very difficult. So imagine if someone is having these delusions and they're having auditory delusions and they're having this in their head and that's what they're hearing, and they can't function correctly. So people with schizophrenia, like I said, with these delusions and hallucinations, they will hear things and they will see things that are not there. Those are some of the key symptoms of that. Emotional disturbances are also key to that. People that have no affect, their affect is flat, taking things away from what you have normally. So schizophrenia definitely is one of the ones that is higher on the scale, and it is very, very, it's very hard. If I had to deal with that in my head, that'd be very, very troublesome. So I'm gonna pause the video. I just wanted to bring that on so you guys can kind of experience that. But this chapter was very, very informative when it came to all of the psychological disorders. Please do look at the other ones that we have on there. They have dissociative disorders. There's trauma, anxiety, and stress disorders. Eating disorders is another one that would have been really, really good to expand on. But I think it was very important because I wanted to share that example with you guys as to what a person that's having those auditory hallucinations and delusions is going through. So yeah, it's very difficult because with schizophrenia, it's a biological and environmental influence that can cause it. So it's not just something that's happening in your brain, it's also things that are going to be introduced by the environment, and it obviously changes what's happening in your brain. So it makes it very difficult to be able to function and to be able to live and have a good life when this is not controlled. So definitely it's something that we have to encourage and have to keep giving assistance to those that need it, and getting them into clinics so they can go ahead and get evaluated and able to go on to medication and do what they need to do to treat that. I apologize, I'm still kind of shaken with hearing voices, but I hope that you enjoyed this video and I hope it was informative for you.